You are listening to Breaking the Waves Conversations about the Dutch Pandemic. My name is Matt Cornell, and I started this project to be a resource for English speaking residents of the Netherlands and anyone from anywhere in the world who would like to know more about the unusual response to the coronavirus in the Netherlands. My guest today is Dr. Amrish Baidjoe. Amrish is a field epidemiologist and public health microbiologist who works on humanitarian health emergencies and has worked for the WHO Health Emergencies Department and different humanitarian organizations. He currently works with the Norwegian Red Cross as team lead public health and surveillance within the Disaster Risk Management Unit, and is an honorary assistant professor at the London School of Hygiene and Tropical Medicine at the Department of Infectious Disease Epidemiology. He has worked on the ground in several large outbreaks and emergencies. Our conversation was recorded on Thursday, April 29th of 2021. Well, Amrish, I want to thank you for agreeing to talk with me today on Breaking the Waves. I think a lot of our listeners may not be familiar, or some of our listeners, especially international, will not be familiar with the Red Team. So can you just tell me a little bit about what the Red Team is and what it does?
Yeah, so the Red Team was formed last year around June, July, August, in a period when we saw basically the first, let's say, doubling of cases, not hospital cases, not intensive care cases, but cases, people with a confirmed test. And we felt that as an alarming signal because it was an early precursor of an infection increasing and kind of like, the wave, as people like to call it, increasing again. So it started with basically four of us: Arnold Bosman, Wim Schellekens, myself, and Sander Koman, writing a letter. Basically an open letter saying, hey, we think this is an alarming situation. Very quickly after, we found actually through social media people who were already actively engaged either in the debate or in social media, especially a lot of people that tried to give context to the complexity around the numbers and the background behind them and tried to explain it. Something that was kind of lacking, I felt, for a long time in the Dutch media. Especially during the summer, we all tended to kind of behave like the pandemic was over, which it wasn't, but mobility did increase. So the idea why we call it a Red Team is kind of to have the idea of, the constructive two parallel streams. For example, you have one working stream, which is kind of officiated and both teams kind of work on the same subject, but the idea is to keep each other sharp. So that's kind of why we picked the name Red Team, to kind of reflect on a Dutch policy, either exerted by policymakers or by our Dutch OMT. There were a few heavy subjects on the agenda at that time. Of course, the use of protective gear in the broad spectrum of healthcare, including the elderly care settings, as well as just the use of mouth, nose mask and protective equipment in the general audience, in places that are a little bit more confined, where ventilation is a little bit on a down low, where people should protect masks. And as you know, it took a long time before that decision was then overturned by politicians and kind of came in effect. So and it was also the other thing that we kind of tried to look more from a holistic or a meta perspective, is definitely looking more at how we approach an outbreak or a pandemic of this scale in the Dutch context. Talking about, if you see these small increases, what does it indicate? What are the core pillars of an approach which you should be investing in? The severe lack of social scientists and community engagement within the response, and in general the integral thinking. Which people tend to find a fake word, but integral thinking means that you think across all pillars. Having worked in several health emergencies with different organizations, we always tend to approach outbreaks from a technical point of view, and they similarly did so at the West Ebola outbreak. And they quickly realized that, your best tool in combating an outbreak are actually communities. And not just a victim of an outbreak, but they're your best tool in the sense that if you utilize communities and you motivate communities as best as possible, they can become a big asset. In the scope of this outbreak, you could see it in the efforts of around contact tracing, where Germany and Canada were in the forefront, in Australia, of understanding the pivotal role of contact tracing in this outbreak. It took the Netherlands a long time to realize it was an important tool, even though WHO was calling, test, trace, isolate as kind of like the three center pillars of response. And it led to the fact that, with the GGD's being in the state that they were, with cutbacks over many years, that you don't have that capacity at hand to roll out contact tracing, which is a very intensive operation, right? So for that, you need to recruit people from your communities, people outside the traditional public health system, something that we in the humanitarian sector and the emergency response sector are very familiar with, since we typically deal with shortages of resources. But it took a long time for the Netherlands to kind of realize that and kind of take that approach. So these were kind of like the pillars that the Red Team was kind of focusing on, looking at the holistic approach to thinking out scenarios, arguing different strategies, but mostly a strategy that focused and still aspires today to push infections towards zero, not being hindered by a lack of reality that we will actually achieve zero with the state of the pandemic at this moment, but there's definitely much more between zero and what we are doing now.
So let's talk about the team aspect of Red Team, because you mentioned that, well, of course, everyone based on their own discipline or training is going to have a particular way of looking at the pandemic. Can you just talk about the different backgrounds, like of people involved in the Red Team?
Yeah, so it's kind of an ensemble that is kind of multidisciplinary in the approach, that we're not all hardcore academics. Frankly, I'm associated with the London School of Hygiene and Tropical Medicine. At the time, Sander Koolman, who was recently, due to personal circumstances, stepped out of the Red Team, was associated, or is associated, of course, as an associate professor at the VU. And Marino, the famous data person in our team by now, at least for the people that follow social media, is also a PhD student. But we were not hardcore academics in the sense that we, are all professors. One of the things that really strengthened, indeed, like I said, is that multidisciplinary approach. So we have people with a social science background. We have people from, nurse Nienke in our team. We have Arnold Bosman, who, just like me, is a field epidemiologist. So field epidemiology being one of the, let's say, training programs founded by the US CDC and the Canadian Public Health Agency about 50 years ago, with its core pillar to strengthen health systems and train people with 2 years practical training or on-job training for outbreaks. And I think that's kind of like, and we, of course, Sander, like being a health economist. We have Wim, who was like a former inspector of healthcare, who understands kind of like the political kind of form of like how things go. And we have people who are just good with numbers and people who like to learn. We have two people who are specialized in complexity, very complex problems, Bert Slachter and Peter Slachter, who wrote amazing pieces within Follow the Money, approaching the pandemic or approaching pandemics in general, like the Delta Werken, something that requires core funding for that once in 100-year event that's bound to happen, who wrote pieces around how we look at elderly people. And how we kind of, say that maybe they're kind of like expirable in our society. We call them risk groups, and it's not too bad if something happens to them, and then completely haven't forgotten how interconnected a society is. So kind of that's the multidisciplinary approach, which actually was brought by coincidence together, right? So for me, it's not the academic titles that matter. For me, what matters is the ability to exchange thoughts, to formulate policy, to, like the OMT, look at international evidence, but also name and acknowledge the large amount of uncertainty at the start of a pandemic or when a new novel disease emerges.
Great. So you have a lot of background in doing field work in East Africa, right? I was wondering if you could talk about how that region is doing compared to European countries or the Netherlands specifically.
Well, yeah. So I have experience with outbreaks globally, and obviously many of the serious health emergencies do occur on the African continent. Many different reasons, right? Weak health systems, lower resources quite often, and with that more conflict, for example. There is also a difference that makes it very hard to compare countries, and that has to do with the risk factors that we associated with this virus. One is age. So the age demographics on average for Europe, I believe, is around 43 years. For the African continent, it's about 19.2 years, if I'm not mistaken. Then the prevalence of non-communicable diseases, diabetes, issues with blood pressure, cardiovascular disease in general. The prevalence of those diseases is much higher in Europe than it is on the African continent. Now, taking into account these two kind of like precursor risk factors, that also means that it's logical to see more severe outcomes. And with severe outcomes, I mean severe disease, IC admissions, as well as mortality on our continent, on the European continent, that you would see in Africa. Now, does that mean that there is no mortality? Does that mean there is no impact of disease on the African continent? Not at all. Also, Africa knows a lot of heterogeneity when it comes to these things, right? If you look at huge capitals like Nairobi, there is a big layer or increasing layer of the population that does suffer from these so-called non-communicable diseases. And you do see impact there as well. That differs very largely over the continent of Africa and sub-regions within countries. Now, one thing I do think that people in general, and I'm generalizing here because we're talking about 50 plus countries on the African continent, do better is the fact, because they have to deal on more frequent basis with outbreaks. They have to deal more frequently with a severe lack of resources, not well functioning surveillance systems, severe lack of lab capacity. They've become heavily reliant on communities, right? And it means both for surveillance activities, for example, through community-based surveillance, where you use people from the community to go door by door and see if people are sick. And if they are sick, you try to refer them to a hospital, or you give them basic advice for health, as well as using communities for contact tracing. I mean, contact tracing is not just a way to, identify someone who's been infected and identify its contacts. It's also a way to engage with people. So you might be infected. That means you actually have to be in quarantine. That has consequences for you as a person. It might mean in each country that you can't work this week. For us, that might be okay because we have some savings on our bank account. We have a social welfare system. In other countries, this might very well mean that you don't have food on the table today, nor that you can feed your family, for example. So this reliance on communities has this effect that you make a response more integral to it. You listen to communities and you work on communities in the sense that they understand what the problem is and what their part is in a solution. It also means very practically that we engage very much on the local level with leaders of communities as well, champions of communities as we call them, and that we recruit people from those communities to assist us in strategic parts of the work.
And this involvement of communities, is this something that you see lacking in the Dutch response?
Yes, I do think I see that lacking. First, contact tracing. It took a long time for the Dutch to acknowledge, for us in the Netherlands to acknowledge that contact tracing was important and that we should have recruited people from community straight on. Very intuitively, both the Germans as the Australians said, listen, we have a lot of students and they have side jobs next to their studies. Universities are closed. Let's give them an opportunity to earn some money and to work as contact tracers, people that we need. For the Netherlands, that took a long time. And then finally, when that workforce was built up in the summer, when cases went down, they scaled down again, even though, there was initially double of cases. There is also the other element that I think we fail sometimes to recognize in the Netherlands. Although we're a very prospering country, we have 2.5 million people. We're kind of low on the literacy index, right? So where do they get their information from? I mean, will they go to the RIVM website? I doubt it. Will they listen to the press conferences? I doubt it. And maybe they will just look at snippets. Where those people probably, with a high likelihood, get their information from are the short snippets that you find on social media. And the accuracy of that information is not always very well fitted. We also still have a lot of people in the Netherlands that don't speak Dutch. And I'm not talking about the typical expat population. I'm talking about people that are also sitting slightly lower on the socioeconomic ladders. And we know by experience that when it comes to crises like this, those people are always affected much more strongly. It took the Dutch quite a while to translate information in different languages. And still, up till this day, there is a limited availability of information for these type of specific groups.
And that seems to have been a mistake on a number of levels. Like, for instance, what I've seen is that migrant communities have been hit especially hard in the Netherlands. The data that they've managed to gather shows that especially poorer and migrant neighborhoods have faced a disproportionate toll from the virus here. Do you think that that's related to this inability to get messaging out to those communities?
In part, it's the messaging,
yeah,
which I think is absolutely pivotal. In part, it's also the status that people are in, right? Are those people in jobs where their employer tells them, listen, if you're sick, you don't have to come? That doesn't just go for people that are, Dutch residents and Dutch citizens, but it also goes, for example, for people doing seasonal labors. The people working in the slaughterhouses were a great example, right? Yeah. They were invisible. And I think that's always something, like I said, you have to take into account. These are the groups that are often hit hardest because A, they're not the most focal groups. B, there are often groups that struggle a lot with the availability of information and how to interpret that. And then B, to effectuate the measures that you want to have to prevent transmission of disease are often affecting them worse as well. Right. So it's not just the impact of disease. And then, of course, we know that the prevalence of the so-called non-communicable diseases is higher in those groups as well.
Yeah, but I've also seen quite a bit of, I guess I would call it blame of those groups in the media. For instance, about a week and a half ago, there was a story in AD, a newspaper about the Indo-Surinamese community and how a number of like the death rates were much higher, mortality rates were much higher in this community. And the article was essentially blaming obesity and saying that what was needed was a sugar tax. And it just occurs to me that that's really a way to blame people for a really complex situation and ignores the fact that the government should have been protecting them in a much more proactive way. What do you think about this kind of tendency to blame communities for the conditions that they're living in?
I mean that's something that obviously doesn't resonate with me in the sense that it's something that I work as a humanitarian worker in some of the most vulnerable places, some of the most complex emergencies in the world, and blaming communities, first of all, it's not helpful. B, it's not going to solve the problem. If anything, it's gonna, put a lot of tension on actually finding solutions and therefore, saying, well, we need a sugar tax. Okay, great. If we need a sugar tax, I'm all about preventive measures to get people more healthy, but we're in a crisis. We have an immediate problem. The task of a government is to protect its citizens. There's a duty of care as well as with employers, as well as with governments. If you don't provide the correct tailored and packaged information to communities, then you're clearly not doing your job. For me, that is very evident in the Netherlands. And that is something that I'm very vocal about because, I was born in communities like that. I know to some extent because, now I work and now I live in Oslo, which is, one of the rich cities, and I'm not in those communities anymore. But like I said, my work focuses very much on it. The job of a government should be, listen, each country has their vulnerable populations. We can argue whatever the reason is that those vulnerable populations are there. They're more vulnerable disease. Our job is to make sure that the information lands there, that we support people in making sure that mortality and morbidity is as low as possible. That's our job. Everything else, we should systematically improve to get those communities out of those positions. But it's not something that we're going to resolve in the scope of this crisis, right?
Yeah. Let me follow up on a couple of things that you mentioned in your earlier answer. The first one was you said that it took a while for the Netherlands to realize that it needed to do contact tracing. Do you think, I spoke with, in my last episode with Mick Block, who says that a lot of what we perceive as incompetence was part of a deliberate strategy to promote herd immunity through natural infection. So, in other words, the reason the messaging was so bad or contact tracing was not a priority was because the idea was to get as many people infected as quickly as possible while supposedly shielding vulnerable populations. Do you agree with that analysis of the situation, or do you think it was really just that the government was slow to respond?
It can be both. I mean, I do think that within the government there was an initial outline, and not just the government, but some of the the people that feed the information, some people from the OMT. There was definitely a thinking that, listen, we're not going to get rid of this disease, so the best thing we can do is shield vulnerable populations and let the virus go around so that we generate immunity. Um, for me, not just for me, I mean, also my colleagues at the WHO were kind of like amazed by this type of thinking, because especially initially on this outbreak, you're dealing with a new disease. There are too many question marks. So it's a high risk kind of like approach, right? While we were not exploiting efforts around mitigation, around suppressing the virus, right? So letting the virus go around with a lack of data around, will natural exposure amongst low-risk groups generate protective immunity for the duration of this pandemic? Huge question mark. Up till this day, still a question mark. So I'm not sure if it was like a conscious approach with ill intent. I do think that people thought that this was the only option we had. I don't think that was the only option we had. Many of the professionals globally don't think that was the option we had. And the Netherlands was not alone in this, right? The UK pursued a similar strategy, but they changed their opinion under a lot of pressure from other scientists as well, but also because clearly this approach was not preventing ICs from overflowing. And it sustainably kept pressure in healthcare systems so high that it was not a sustainable approach. Sweden is a different story, right? That's where they openly spoke out about it and said, this is what we're doing, and then later on denied it. Now, listen, for me to kind of recollect what happened and how it happened, that's not up to me. There will be a parliamentary inquiry to this whole process. I mean, that's detective work. That's not me. My goal is really to show that there is an alternative to the approach that we're having. So the steering on IC capacity, or controlled transmission, as our prime minister calls it, is not a good strategy. It leaves too little buffer room for when things go wrong, right? When vaccinations are not rolling out fast enough, when a new strain makes its entry and it's more transmissible.
It also seems to assume that death is the biggest concern, which what we're now learning is that it may be that long COVID is actually one of the major consequences that we're going to see here. So even while the Netherlands now has managed to really bring down the overall death rates, if they're estimating 10% of the population that's been infected might end up with long COVID, that's hundreds of thousands of people.
Yeah, so there's a lot of unknowns around this virus, and also for that reason, it's a good strategy to bring infections down.
Yeah.
For all reasons, it's a good approach to bring all infections down. I think what we're trying to do now, or what it seems to be a passive approach, is that the government came with a new strategic roadmap, right, to the approach, and you have these 4 categories of scale in terms of severity of the number of infections. We're still in the highest level, and for some reason we've normalized at the highest level, right? And we've never made a serious attempt not just to go one level lower, but actually go to the lowest level. And what we're kind of hoping is that vaccines will help us out of the situation. And for a large part, they will. On the acute front, vaccines will definitely get out of this crisis, because they will relieve pressure on the healthcare system. The question is, if we only focus on that pillar, that only works if you can guarantee that there will be no escape variants. So variants that will, be able to pass immunity or bypass immunity that was kind of extracted or instigated by the vaccinations. And that's a risky assumption to make, right? Looking at the situation in Brazil. So what happened in Manaus and then kind of spread out over now to the South American continent, to look what's happening in India. With all the unknowns, with all the uncertainties, I keep on emphasizing those. So you can't be focusing on a single solution like vaccines. You need to strengthen over the whole range of fundamentals. Communication, test infrastructure, tracing, contact tracing, and then vaccinations as they roll out. You can't neglect either of them. It's not over till it's over.
There were reports, of course, this week that with the crisis in India, that at least this is anecdotal now. Of course, I know that the science hasn't really weighed in yet, but that a number of fully vaccinated doctors are saying that they have caught COVID during this current outbreak. And it looks like they had the AstraZeneca vaccine, which might have a lower efficacy against variants. I have no idea. What do we know about the presence of variants right now in the Netherlands? And should we be concerned about immune escape?
Well, immune escape is going to happen, right? I mean, that's a given. The speed by which it happens depends on several factors. A, how effective is your vaccine from the onset, right, against whatever is in circulation? B, how much of the virus is still in circulation in places where vaccine coverage is low? Well, fact is that it's kind of like still the global image, right? So yes, although you might vaccinate your high risk groups and you see an immediate downfall into cases in the hospital, in the ICs, you still have transmission ongoing. It's just not transmission in individuals where the outcome is severe. That this is going to happen with the way that we globally approach it, and that's kind of like the scope we have going. It's very likely that this will happen. Fact is that our vaccines are not 100% effective. They might be scoring very high at this point in preventing severe disease and mortality, but they are not 100% effective when it comes to inhibition of transmission. So you will see reinfections here and there, but the good thing is, and it's a good thing for us all, right, that this most severe outcome, for a moment, that stress is gone, which gives us time to prepare, reunite, and align strategies. We don't have to do it globally straight away, but it's not going to work. But it gives us time to speak with our German neighbors, with our Belgian neighbors, with our neighbors in the UK, and say, okay, now that the acute pressure is gone, we're still in a very worrisome situation. How are we going to align our strategies? How are we going to move forward together? Right? I mean, the science has shown that the synchronization of policies across neighboring countries or regions is not only just more cost effective because you can initiate and synchronize, whatever measures earlier on, you can also release them earlier. That has economic benefits. It has a lot of benefits for mobility across borders. And we are a mobile continent. I've loved Europe for being a mobile continent, right? That we can move from one place to another. And that creates great opportunity of combating this virus as well. But if we don't do that, it actually gives us a bit of a problem.
And of course, not just within Europe, but if we don't get vaccines to the rest of the world, we're not out of the woods either, right?
No, that's absolutely true. And the thing is, like, synchronizing the world on whatever subject will never happen at one point, right? So you need to start showing leadership from single countries, expanding to our neighbors, and then hopefully, doing that globally. Now, that's an ambition that I have, right? So a crisis can be detrimental to humankind as a whole, but approach a crisis in the right way with the right leadership, and you might actually build really good things, right? If we use a crisis, for example, to also make more resilient healthcare systems in countries that don't have them yet, you make sure that they prepared very well for the next one as well.
Let me take you just a little bit back to our national or local situation. You mentioned that a lot of people in the Netherlands get their information from little snippets on the news or from social media, and not even at the RIVM website, which RIVM is like the Dutch CDC. What about the accuracy of the RIVM's claims? Can you talk about that? Because I know that, for instance, as of now, their website says that aerosol transmission still plays little role in the spread of this virus. They still say that masks are probably not very effective. And as far as I know, they have been downplaying the role of asymptomatic or pre-symptomatic transmission. What needs to change in the messaging from RIVM?
Well, there is no effective one single measure, right? When it comes to all these interventions that we have, of let them call it the non-pharmaceutical interventions, the effect of them is a cumulative effect. not just cumulative in the sense that, you have one intervention that's 3% effective, the other 6%. No, they differ. There's a spectrum of effectiveness for different interventions that depend very clearly on the context. First context, incidence. How high is the incidence in the community, right? So what is the chance of you walking somewhere in a building and by random chance facing an infected individual? The higher the incidence, the higher the chances. Ventilation plays a role. I mean, that has been established. I'm not aware of the content of the RVM, but WHO, ECDC, US CDC, they all acknowledge the role of one of the main transmission pathways being the aerosol transmission pathway, right? So ventilation is an important subject. The use of mouth-nose masks in confined spaces with people in them is important. And I think, undermining that and saying, that that's not a transmission pathway, or saying, no, that's not the case, creates also a false sense of security.
Okay, so just to be clear, like for instance, right now, as you mentioned earlier, we didn't get a mask mandate in the Netherlands until December of last year. But as it stands, masks are only necessary when you are entering a building or walking through hallways. So, for instance, at the university campus where I teach, or at the pharmacy that I go to pick up my medications, they take off masks when they're seated or standing, on the premise that once you're 1.5 meters away from another person, you're no longer at risk. Is that true?
No, that's not how aerosol transmission works, right? The whole damaging part of the whole negative part of aerosols is that the particles are small and they keep on hanging in the air for a longer time. Which means that theoretically you can walk through a cloud of infectious particles that are hanging or just have been sneezed. And that's kind of the whole thing, right? If you sneeze or you cough or you yell really loud, there's a spectrum of particles coming out of your respiratory pathway, either in your nose or your mouth. Some of them keep on hanging. That's what we call aerosols. And some of those aerosols contain virus particles. Some of the bigger drops are not too much of a problem because they will land. Right, so those are the ones for where you could say, okay, keeping 1.5 meter distance, fine. But then the problem is those particles that keep on hanging in the air. So from that point of view, that advice is not on the safe side, right? And there's also the other thing that I have to mention. In the end, it's also about what is the downside of implementing a certain intervention, right? So I never understood the opposition against mouth-nose mask, and a lot of different arguments were used for this. And I got tremendously frustrated by it, because for me, this was not science anymore. This was scientism. This means you believe in your own preconceived thinking and then focus on a very strict piece of evidence and forget about all the rest. Even more so, you're so stuck to facts that you only accept evidence almost from randomized controlled trials, which is the highest form of evidence. And you disregard everything as observational evidence, or disregard anything for which you could say, let's apply the precautionary principle, right? If it does not do harm or significant harm, let's just do it and try it out. That's the case for mouth-nose mask. And we got these really ridiculous reasons of like, yeah, if people use mouth-nose masks, they won't keep distance from each other anymore. And then I thought, but that falls or stands with the communication campaign that you're going to hinge on to the mandate for people using mouth-nose masks, right? Yep. And that communication campaign never started. Even though it was decided that mouth-nose masks have to be used here and there, there was never a communication campaign on them. There was, I think, one talk show that did a little bit about it, and then I did an episode with, the NOS Corona Fighter versus Fables, where I demonstrated how to take one on and take one off and how to responsibly store it.
There was also quite some Orientalist discourse, racist discourse around, other countries wear masks because they're more obedient in Asia or something like that. I remember personally, I was wearing a mask on the street in Amsterdam in April, and someone came up to me and started calling me Chinese. So I think there was also this sort of cultural bias that to wear a mask was to be associated somehow with, Asian countries, Asian cultures, and that it meant you were obedient to authority or something like that.
Yeah, that is something that, again, we're not the center pillar of society in the West, We can learn from other countries.
Yeah.
For the sake of not reinventing the wheel, we should learn from other countries, because in Asia, they have tons more experiences with respiratory diseases, outbreaks of respiratory disease. So looking down on other people is not just, almost putting it into a racist narrative. It's also severely inhibiting yourself to help your own society. And that kind of is the center pillar of response, right? We shouldn't be, during a pandemic, which means that these are outbreaks that hit the world globally, be reinventing the wheel in each and every individual country. That's just stupid, isn't it? Like, we should try to learn and adopt lessons from other countries as best as we can, and especially those countries that have experiences with outbreaks.
Let's also just briefly talk about this the role of pre-symptomatic or asymptomatic transmission. I attended a university talk by a couple of representatives of the GGD, or public health representatives, and I think this was last fall, and they were talking about campus safety and contact tracing and things like that. And one of the things that was brought up was the issue of testing, and at that time, and I think it still is the case here in the Netherlands, that they only recommend testing if you have symptoms, or if you've been exposed to someone, if you've been in close contact with someone who has tested positive. And I asked the question, well, isn't the virus more contagious 1 or 2 days before the onset of symptoms? And the person from the GGD said they were not aware of that. They said that there, as far as they knew, you could only transmit the virus while you were contagious. It's also something my GP told me when I asked her to wear a mask. She said the virus is only contagious with symptoms. Is that true?
No, the virus, also, like, virus expression is a spectrum, right? So at the point of you having symptoms, we're talking about respiratory symptoms, right? And actively coughing and sneezing. You might be on towards a peak of also the viral load in those fluids, right? So that means that the chance of you then at that time infecting someone else, due to two components: a, the fact that your viral load might be higher in your excretion organs, in your nose and in your mouth, and in your lungs for that matter, as well as you coughing and therefore transmitting virus is higher. But since we know that aerosol transmission is also an issue, you speaking really loud at an earlier stage and not being coughing, but having a certain viral load, you might be able to transmit the virus as well. Again, it's all about risk perception, right? So yes, a symptomatic individual might have a higher viral load, might have mechanisms to strengthen the transmission pathways, as I said, by coughing and sneezing, but it doesn't exclude pre-symptomatic or asymptomatic individuals from transmitting. In fact, we know from other diseases that asymptomatic transmission does occur. So yeah, if you are in the pandemic and your infections are high, you want to grasp every faction, right? So you want to grasp your symptomatic people, you want to grasp your asymptomatic people. That's from the perspective of infection prevention, right? So measures you can take. When it comes to testing, these are different stories, right? So we have to look at things in context. Testing capacity, right? So if your testing capacity is limited, you kind of want to make sure that you test people that most likely have the virus, right? So these are symptomatic people with a certain set of symptoms which are very specific to COVID. And that's a problem, right? Because many of the symptoms are a little bit generic. When testing capacity is not an issue, you might want to expand your case definition to close contacts, less close contacts, and maybe routine screening with a rationale, right? Ports of entry. We know from contact tracing data that the workplace is actually in the top 5 of places where people get an infection. So screening every person that enters a work floor, if the employer has the financial resource for that with a rapid diagnostic test, will filter out people. Again, this has to go hand in hand with supportive measures to the persons that have to go in isolation. Screening people at school. Schools are tremendously important. If we can massively reduce the risk of infection at schools by paying attention to ventilation, paying attention to other infection prevention measures, doing port screening, I can confidently say when transmission is low in communities, then we can reopen schools safely. right? But the crux is indeed having community transmission at a low threshold. If you only focus on symptomatic individuals, you're in a loop, because people will almost always, progress from asymptomatic, pre-symptomatic to symptomatic, or remain asymptomatic or almost asymptomatic for the duration of an infection in any case.
You mentioned schools. Schools in the Netherlands were reopened without protective measures, so without masks and without physical distancing. And tests were discouraged, at least before the second wave. Tests were discouraged in children, I think, under 12. And the RIVM stated that children played little role in the transmission of the virus. Is that true? What does the evidence tell us about children and schools in this pandemic?
The evidence tells us that everybody plays a role in transmission, but that there is a spectrum of that role in attribution, right? So young children play a very small role, and as children grow older into young adults, they play a bigger role. That's what the evidence tells us this time and age. To exclude schools of all ages completely, I understand why people did it, right? You want to, schools are important. They are super important. But yeah, children are not, an isolated population groups. They live with parents. They might live with grandparents. They might live with multiple families in a house. So if you allow infections to spread in schools by not taking any infection prevention measures, then infections will spread from children to adults.
Yeah, and I guess at the time that we're recording this, it's been reported that 51% of Dutch primary schools have had outbreaks in at least one class since they reopened schools.
Again, I mean, that's the thing, right? There is much possible to prevent infections in schools. I'm not saying closing schools, right? Yeah. Closing schools, we did that for the right reasons because incidents became so high, but it should be the last resort. Again, very much in line with the WHO advice, right? And the best way to do that is A, to reduce community transmission, and B, to make sure that you have the right infection prevention measures in schools.
What did they do in Norway?
To be honest, we arrived in Norway in November. So there's two things that I did in Norway, right? My girlfriend works at the Dutch for the Norwegian RIVM, Volkshusinstituut. There's a few different things that they do in Norway. A, they're very much on top of things, which means that with the early increases, you can see a lot of measures early on being implemented, right? B, their communication strategy is very different. It's very communicating with people, right? It's not telling people what to do, but it's really creating a feeling of solidarity. Let me give you a few examples around their communication strategy. One, if I fly into Norway, get a text message on my phone. On my Dutch SIM card, I get a text message in English. On my Norwegian SIM card, I get it in Norwegian saying, welcome in Norway. These are the rules. This is what you have to do. Norway started in December with their quarantine hotels. If you come into the country, you can't give a negative test. Sorry, it was November. You have to go into a quarantine hotel for 10 days. Rooms in the hotels are 50 euros a day or $50 a day, something like that. If you can pay for it, the government will try to assist you as best as you can.
And that's a good, as I understand it, that's a good price on a hotel in Oslo, right?
That's a good price on a hotel anywhere in the European continent, I would think, right?
Yeah.
So, and I mean, the hotels are out of, don't have much business anyway. So this at least generates an income for them as well. Then secondly, every time their prime minister holds like a press conference, which is almost a weekly thing, you get a text message on your phone. Again, on my Dutch phone, I get an English message. On my Norwegian phone, I get a message in Norwegian with the very simple message: we need to do this together. Please stick to the rules, and a link. You click on that link, you get a bullet points of measures for the different like sub-districts in Oslo and through Norway, right? There's a lot of heterogeneity in the incidents in Norway as well. Other things that they do, which are a little bit over the top, we need to mention it as well. So we just got a kit on the 13th of April, and thank you. And I couldn't attend the visits to the doctor with my partner, which was incredibly frustrating. And unfortunately for us, things were going well, but I can imagine that people receive it as moment bad news as well. And it's an important thing that you want to experience with both parents. You want to see the ultrasound of your newborn. We're a year in the pandemic. You can wear the protective equipment to almost reduce the risk to zero. It was also quite difficult for me to attend the whole pathway of the birth of my son. Which was tough on my partner, as well on me to some extent, because this is the place I wanted to be. That's completely unnecessary, right? So there's this exchange as well where you want to push risk to zero and not accept 1 or 2% risk. While incidence is already quite low in Norway compared to the Netherlands, right? So we should get away from those dichotomies, right? That the choice is 0 or 1. There is much more between 0 and 1.
I want to ask you about one of the tools that could lower your overall risk profile, which is rapid antigen tests. As many people might know, now you can buy a rapid antigen test at Albert Heijn or Etos. And could you talk about these tests and whether you think that they're a good strategy for reducing our risk?
Yeah, so they're a good strategy to lower incidence in communities or in countries, right? But if they are they're definitely a good tool, but they hinge on the implementation. And I think that's kind of like where we might be missing out. First things first, right? I'm not a proponent of like at-home testing. Why? You need good instruction. How to apply a test properly with the current generation of rapid diagnostic tests. Maybe with future generations, it becomes easier because there's a lot of innovation in diagnostics happening. B, if people test at home a lot, we miss a lot of what's happening, right? Because they are not reporting the data to the RIVM or to the GGD. So we might be losing out on a little bit of that. And there's a C as well. And at C is you might create a dichotomy in society where you have a category of people that can afford testing by a high routine and people who can't afford it, right? And I think that the whole focus on the event sector and kind of increasing the mobility in the event sector kind of shows where our priorities lie. They lie very much to a more wealthy part of our society and not so much to a part of society that's inhibited as well, but will never ever be able to afford to go into costly events like this. If implemented well, I think the core implementations are obviously at schools, right? Workplaces. Follow a South Korean strategy. Build a testing. How do you call them? Like small testing facilities on every corner of every kind of wijk, that you have in the Netherlands, so every kind of like sub-district. Reason being, you have specialized staff taking a test. And specialized means someone who followed a day of training. You have someone who can interpret the test properly. You have someone who can make sure that the data is collected properly and sent off to the RIVM or the GGD's. You have someone who can instruct people what to do with the result, right? And I think it's a much better investment than kind of leaving it now open to the complete free market and everybody does whatever they want to do with tests and not so.
It's a good point. I have a friend in Berlin who says that she has access to free rapid antigen tests, but she actually goes somewhere and someone administers the test. And then she has a result that she can use within a 24-hour period to go to get a massage or visit a dentist or something like that. And what we have now in the Netherlands is, you can buy it. It's sort of like the mask policy. You can use it if you want to, but nobody's going to make you do it. I know that, for instance, in the university context, they're now going to make rapid antigen tests available for students, but they're not going to require a negative result to enter campus. And I noticed they don't even say we would strongly advise you not to come to campus if you test positive. So they seem to be, as you say, leaving a lot up to individuals to judge risk again. It seems to be a lot of sort of privatization of what should be a public health sort of decision.
And I think it's maybe kind of like, tipping on the center pillar of the Dutch approach, or, the approach that the Dutch government wants. There's a lot of own responsibility in this. That's problematic because, yes, in the end, it's own responsibility. But it accumulates into community responsibility, right? If we don't manage to control this virus as a community, we all experience the negative side effects of it. A crisis like this yells the necessity for collaboration. Hence, there is no collaboration. There is a lot of of course there's a lot of collaboration, but I mean, kind of overall, there's a lot of advisory committees. There's a lot of fragmentation in how different scientists are brought together, for example, on the different platforms to discuss solutions, to openly discuss scenarios of what it can be. That includes the scenarios of groups that I completely don't agree with, like Herstel.nl. Even those scenarios we have to discuss because they are there.
Yeah, I mean, I just have to say, like this one of the reasons I started this podcast and started reaching out to people like yourself is that not only am I, a foreigner, like someone who's, an outsider to the Netherlands and has difficulty navigating the news landscape here, I'm also in a risk group. So I've basically been shut inside my apartment for well over a year now. And I've gotten the sense that I'm on my own, in the sense that I'm welcome to take whatever risks I want to, or I can be as cautious as possible. But I don't get a sense of, a lot of solidarity in that struggle. So that has been really unfortunate. So, even this issue of rapid antigen tests, I bought one of those tests so that I could feel comfortable having dinner inside my friend's apartment, because I haven't been indoors with, strangers or people outside of my household very often in the last 14 months. So, this policy, or the sort of Dutch approach, seems to rely heavily on this idea that we're all sort of individuals who are managing our own health on an ongoing basis and taking our own risks. But of course, we're in a very high risk society right now. I think there's 25 safety regions, and all 25 are in the highest level of risk.
Yeah.
Right now.
Yeah.
So
no, I mean, it's something that I hear. I mean, in all the reach out that we get as professionals, definitely one of the groups we don't hear a lot about are people in those risk groups themselves, people that have been putting themselves in quarantine or in isolation, to say so, for the last 14 months, because they know that if they get infected, there's a higher risk for severe outcome of disease. And I think that's kind of like, what puts that solidarity principle down as well, is that as a crisis endures, solidarity dries up as well, especially if you do nothing to really build it, right? To kind of show people that, we're in it together. And that's something that I felt the government to be very passive about as well. Not just our government, governments globally have made this mistake. I mean, the fact that 14 months in the pandemic, we still don't have a highly synchronized, policy in terms of approach to this pandemic with Germany or with Belgium, that worries me a lot. I wouldn't have expected that. But yeah, that's how it is.
last question.
Yeah.
Jaap van Dissel steps down tomorrow. You are appointed as the new head of the RIVM. What changes would you make? Whether or not you'd actually want the job. You may not want the job, but if you had the job, what would you do?
No, I think, although Jaap van Dissel's viewpoints and my viewpoints might differ on quite a substantial technical subjects, right? Mouth, nose masks, the inclusion of social science overall as part of the OMT. It's a difficult job. It's a difficult job to navigate between strong-minded politicians, and we can talk about the systematic issues as well. If you see that with the toeslagen affair, which are symptoms of, the same people running the show, a society that has strong-minded people, and it's quite arrogant as well. So am I. I'm one person that is not living in that society anymore, but it's definitely a product of it.
I'm an American, so I come from a very arrogant society as well.
Exactly. And I think that's kind of like, the center pillar. I would not take the job so easily because I'm way too rough edge for that, right? I'm way too sharp. And I work in the humanitarian field. There's that, whatever suffering we have in the Netherlands, there are regions way worse off than the Netherlands that we don't hear anything about. If we think the Netherlands was hit hard by the crisis, yes, that is true, but there is a lot of suffering and that has been amplified by COVID-19 in many regions of the world. That's the job that I do, and that's the job that I'm adherent about. I would recommend the inclusion of people with profiles like mine, at least on a consultancy basis, right? We have crisis responders from Doctors Without Borders in the Netherlands. We have crisis responders in the Red Cross that can tell you a lot about our experience in humanitarian emergencies and protracted emergencies, and how to work with communities and how to deal with communities. So my two clear recommendations would be diversify the home team. Don't wait till after the crisis. Get social scientists and anthropologists in there, deviate a little bit from core academics in the OMT, but get operational people in there, because that's an important thing. There's the academic reality at times, which is incredibly important. Science is our fundament, but you need the operational people that are going to tell you what's implementable and not, and how we need to approach it.
Amrish, thank you very much for talking with me today.
You're welcome.
That concludes my interview with Amrish Baidjoe, which was recorded on Thursday, April 29th of 2021. If you'd like to hear more from Amrish, you can follow him on Twitter at Amr_B. That's AMMER_B. And if you'd like to follow the advice and research of the Red Team here in the Netherlands, their website is C19redteam.nl, and you can find out more about what they're doing to stay on top of the crisis. Thank you very much for listening to Breaking the Waves, and I hope that you'll join us for the next episode.